So for example, we have a patient with an abnormal left ventricle or a left ventricle which is struggling to pump blood out of it. So what will happen? Increased volume and pressures in the left ventricle will also happen in the left atrium and will also have that similar effect in the pulmonary vein and the pulmonary venule. So the compensatory mechanism of the pulmonary veins will be to redistribute the excess volume in the pulmonary venous system, and from the normal appearance of having prominent pulmonary veins at the lower lung zone, you will also have large or prominent veins in the upper lung zones. And this is what we call the upper lobe venous redistribution or stag-anter sign. Look at this stag-anters. This is also known as cephalization. Now, what will happen if there is a persistently increased volume in the pulmonary venous system? There will now be, the next step will be for the fluid to seep out of that venous and the vein, creating your hazy vascular margins. And you'll also have fluid in the interstitium, and that interstitium is the space outside the alveoli and also outside the vessels. Okay, so you'll get hazy margins, perihilar haziness, and also interstitial lines. That's why you'll get these findings. Curly lines, which are septal lines, and perihilar haziness. You also get this peribronchial coughing. So how do we look for this one? We're going to look for a bronchus seen on end, which is adjacent to its accompanying pulmonary artery. Now the bronchus, which is dark or lucent because it's air containing in X-ray, will have that halo or that opacity surrounding it. So that's like a donut sign. All right, because you'll have those distended lymphatics, because the lymphatics are the ones who are supposed to drain the interstitial fluid. So if you have too much fluid in the interstitium, the lymphatics will also be dammed up with fluid. Okay, that's peribronchial coughing. All right, if the there's already interstitial fluid and there's persistently increase in the hydrostatic pressure or edema, the next stage will be fluid filling up your alveoli. This will be shown to us in X-rays with consolidation in the inner lung zones, more centrally in the perihilar region, and that's the batwing airspace opacification. So how do we measure, how do we quantify the stages of the pulmonary edema? It's actually by measuring it with Swan-Ganz catheter, in which you insert a catheter and have a balloon at the branch of the pulmonary artery. So the pressures measured here in the pulmonary artery branch is actually a reflection of what? Of the pressures which are downstream here in the left atrium. So if you have elevated left atrial pressure, you'll have elevated pressure here, as well as in this one in the pulmonary vein, and as well as in the capillary level. That's why it's called the pulmonary capillary wedge pressure. The higher the capillary wedge pressure, the more severe the pulmonary edema is. Okay, so let's take a look at these examples. In this case, you'll have prominent vessels here on top. That's upper lobe venous diversion antler sign. In the next stage, you have prominent septal lines in the periphery, subpleural region. So this is curly B lines. And in the perihilar region, that's curly A lines. What else? You get perihilar haziness, hazy margins surrounding the veins. Okay, as well as you have this bronchus seen on end with a prominent or thick opacity surrounding it. You have a donut sign here, okay, and a donut here. That's interstitial edema. This one is your alveolar edema because you have airspace opacities, fluffy here, more centrally located, okay, creating your batwing appearance. Okay, now let's remember that it's only not heart dysfunction or left ventricular dysfunction which will bring you pulmonary edema, and there are also other causes. For example, if you have a valve here which is not functioning well, you get elevated left atrial pressures, and that's the example of mitral regurgitation. Also, if you have a left ventricle which is struggling to pump against a aortic stenosis, okay, that will create the same effect. So valvular dysfunction will also create edema. What else? Another common example is when you have if you are overhydrating a patient, you will have an overall increase in the hydrostatic pressure in the entire vascular system, and if that happens, you'll also have alveolar edema. Also, in other cases, if you have destruction of the walls of the alveoli, you have diffuse alveolar damage, what will happen? You'll also have edema in the alveoli, and that can create airspace opacification as well, or another cause of pulmonary edema. All right. Thank you very much for listening, and here are the sources of the cases.